All right. Next, we're going to be joined by Dr. Amanda Shakal. She is originally from Dallas, Texas, and graduated from Texas College of Osteopathic Medicine. She then went on to complete residency training in anesthesiology at UT Health in San Antonio. Following training, she joined the Department of Anesthesiology at Vanderbilt University Medical Center, where she served as the co-director for POCUS. After nearly 6 years, she moved back to Texas, where she is an assistant professor at UT Health San Antonio, currently the chair of the Continuing Education Committee and the POCUS director. Her clinical interests, I'm onto this, but regional and acute pain, POCUS, and perioperative medicine. She lives with her husband, her 3-year-old son, and her rough collie in Alamo Heights, where they enjoy spending time enjoying the Texas Hill Country when the heat permits. Today, she's going to be presenting a demonstration on point-of-care ultrasound clinical practice. And please join me in welcoming Dr. Shakal.
Thank you, Dr. Burns. So today, this is going to be the fun part of the session, okay? So it's not going to be quite so formal. I have a few slides, but really my goal for this part of the session is to really get you guys over here with the demonstration part, get some hands-on experience. And so what I have on the slides is not very substantive. Many of you come from wonderful medical schools that have excellent ultrasound curriculum, so I would imagine a lot of what I have on my slides is familiar to you. And as I said, before, I really want the hands-on experience today to be the focus. So we're going to spend a few minutes looking at some slides to really just to highlight 4 main areas of point-of-care ultrasound that are useful in anesthesiology, because of course point-of-care ultrasound is useful for many other specialties as well. So we're going to highlight the 4 areas for anesthesiology and just kind of go over the basic views for those areas. And then we're going to move to our demonstration component, okay? So as many of you know, point-of-care ultrasound is really, truly an extension of the physical exam. It's been mentioned as, the stethoscope of the future. And it is an ultrasound that is performed at the bedside in real time because the ultrasound can be used, by radiologists and other ultrasound technicians. So this is really performed at the bedside to answer real-time specific questions to help you with management. Of course, it encompasses many different things, and as I said earlier, we're going to focus on the 4 main areas specific to anesthesiology, but certainly there are many facets of point-of-care ultrasound. And of course, I can't highlight this enough, the benefits of POCUS and why I, like Dr. Burns, feel so passionate about facilitating the training of medical students, residents, and even faculty members. When we can, acquire these skills, it really translates in a profound way in the clinical environment. So I have spent a lot of my career really touting these benefits and really trying to help educate colleagues, residents, medical students such as yourself. So of course, when we get proficient at this skill, it can help change management. For anesthesiology, of course, we're concerned with perioperative management. It allows you for volume status assessments that can be useful in many different areas in medicine, as with the titration and administration of the inotropes and vasopressors. And then, of course, for anesthesiology, there's always pressures to cancel, delay, should we proceed? And so point-of-care ultrasound has really been helpful in my own practice on making those decisions and then feeling really confident about those decisions. And then I've also used it in the post-anesthesia care unit to help with disposition in patients who may have been previously unstable. So really, like I said, for the bulk of this session, we're going to have some fun and we're going to do some scanning. So we're going to have 2 groups. There is quite a few of y'all, but when the time comes, I'm going to have you split into 2 groups. The first group will focus on the cardiac exam and the lung exam, and then the second group will do gastric ultrasound and the FAST exam. Dr. Burns will be doing the first group, and I will be doing group B. So just again, to highlight those 4 exams, we have the focused cardiac exam, just a brief review of the basic windows. You have a parasternal window, an apical window, and then the subcostal window. And some of the clips on here, I'll admit, are from the internet, and then some are my own personal clips. I didn't have a great parasternal long, so here is one from the internet. And we'll kind of go over the probe placement in the demonstration. This is the parasternal short axis, which is again just kind of the short axis view off that previous window. And then we have an apical 4, and then we have the subcostal. And so we'll go over kind of the probe placement in the live demonstration. For lung ultrasound, there's several different ways to think about how to do an exam. Some do zones. There are some that do, at least, making sure that you cover each lobe on each side. So this was just one that I took from kind of an old paper on how to, kind of think about different zones to ensure when you do your lung exam, you're kind of covering a good area to kind of get the information that you need. And of course, as you guys know, this is what normal lung sliding looks like. And when you use M mode cursor, and we can show you how to do this in the demonstration, with normal sliding, you're going to see that nice sandy beach sign, or some people call it seashore sign. So that's what this is demonstrating. And then, of course, if there's not lung sliding on your exam, you're not going to see that, that motion below the pleura, and so it's all going to be these straight lines, and we call that barcode sign. And this is just an example of a lung point. If you are suspecting someone has a pneumothorax and you see an area of absent lung sliding, you're, of course, you want to go and find the lung point, because that's very specific for pneumothorax. And of course, a really nice example of some B lines. Certainly, I don't think we'll see any of these today on our models, but just something to have in mind. And hopefully, we won't also find a pleural effusion as well. And then now moving on to gastric ultrasound, which is truly probably one of my favorite of the point-of-care ultrasound applications. Just wanted to put this slide up here just to really, I think conceptually with the ultrasound probe, it's kind of hard to understand like what part of the stomach we're really actually looking at. The stomach is, fairly large, and there are multiple areas I know you guys know from your anatomy studies in school. Truly the fundus and the body are full of air, so they're not very easily seen on ultrasound. So the area we're looking at is the antrum, and I've drawn a really nice, beautiful blue line through that. And really, this slide is meant to show the interaction between that area of the antrum and the liver, and then the abdominal aorta, which on ultrasound are the 2 landmarks that we're really going to look after in order to find the stomach. The stomach can sometimes be hard to find, but I find when I find the landmarks of the left lobe of the liver and then the aorta, it's sometimes easy to then say, oh, there's the stomach. So that's why it's really important, really with any ultrasound to really understand the anatomy, because in 3D, because you're translating that into a 2D image on your screen. And then I just wanted to put some examples up here of some different, fasting or non-fasting states. Today, I don't know what we're going to encounter with our models, probably a non-fasting state, but this is what an MPO state looks like. You can see the stomach is pretty small, just kind of sitting right up there by the left lobe of the liver, and then you have a nice cross-section of the abdominal aorta and long axis there. And this is probably closer to what we'll see because people have probably had some breakfast. And this is a late stage solid. Early stage solid's not really worth putting up here because there's so much air that we swallow when we ingest, liquids and food that actually there's a shadowing out of anything below the stomach, and it creates what they call a frosted glass appearance. So you won't be able to see really anything. It'll just kind of be this hazy line of all this air, which creates like a reverberation artifact down, and then you won't be able to see anything. Usually that persists for about an hour or two until the air kind of dissipates, and then you get this image, which is why this is called the late stage solid. So this is probably most commonly what you're going to see, and that's why I included this and not the early stage. Because very rarely, especially in anesthesia, do our patients like literally just eat and then we encounter them. If that's the case, that's really not great. Most of the time when I've found patients who are not appropriately MPO, it looks like this. It's more of a late stage solid picture. And then this is the other most common thing we see is more of a clear liquids view, or this could just be, baseline gastric secretions, not necessarily clear liquids. You can see like the dark anechoic center of the stomach there, and that's just fluid. It could be liquids, like I said, could be gastric secretions. When we find liquid there, whether it be clear liquids or gastric secretions, we do want to assess the amount, the volume of it. A certain amount of volume is okay, and it's really hard to draw that line in the sand, but it has been drawn at 1.5 mLs per kilo by some really smart people, and they then created this table that you can use. So you can do a free trace if you have a patient that has some amount of liquid in their stomach and you're still kind of unsure. It's not food, but you are still concerned that it's a kind of a significant amount of volume that it might put them at risk for aspiration. You can use your free trace tool on your ultrasound machine and draw the outline. You want to ensure that you get the full thickness of that muscular wall there. And then your machine is really nice and it'll spit out the area for you, and then you can use this table. This table is accessible on gastricultrasound.org. You can just literally Google it and it will provide the age across the top, and then down the bottom you'll see the cross-sectional area, and all you have to do is just kind of drag over, and then obviously green means go, and anything in the white, the patient may be at high risk for aspiration. And lastly, we're just going to touch on the FAST exam, which is a newer addition to many of our anesthesiology point of care or ultrasound curriculums. It's been added to our board exam as well. Certainly, it's not a new exam. It's been around, I think, since the 80s, and is used by our emergency medicine colleagues pretty frequently, daily, in the trauma bay. But there are some uses in perioperative medicine as well. Just to briefly go over how to do the scanning technique itself, you can use either a phase array or a curvilinear probe. I prefer a phase array, but either is fine, whatever you have available. Many will start in the subcostal window, and then you move over to the right upper quadrant, left upper quadrant, and then your pelvic windows. And we're going to just briefly look at some of those. So this is a subcostal view. Depending on your conventions of your orientation marker is which side you point the indicator. I have actually, I believe, a cardiac convention clip here, so the probe would actually be flipped. But if you're performing a FAST exam, you're probably using the non-cardiac conventions, in which case the probe indicator will be to the right. So that's just a little detail just to be aware of. This is a right upper quadrant window here. The indicator here is just pointed cephalad. And then you have a nice view of the diaphragm there and the subdiaphragmatic space, and then a view of the hepatorenal space, which is also known as Morrison's pouch there. And you just want to scan through the whole length of the liver and the whole length of that space, which I don't really have shown here, to ensure that there's no free fluid. This is a left upper quadrant view. This one, you're going to need to place the probe a little bit higher. And I didn't mention on the previous slide, on the right upper quadrant, that probe placement is going to be between the 8th and 11th rib space. This side's a little bit higher. It's more like 6th to 9th rib space. And then you may want to rotate the probe towards the bed just to get away from all that air I mentioned that's in the body of the stomach and the fundus. And then here again, we have the subdiaphragmatic space that we can view, and then the hepatosplenic space as well. And you want to scan through the whole spleen all the way to the tip to ensure that there is no free fluid. And lastly, I just included the transverse suprapubic view or pelvic view. There is also a sagittal view as well. And here your indication marker is towards the right. And you're going to place the probe just above the pubic symphysis and then scan all the way through the pelvis, as you can see here. And you may want to turn your gain down just because you can see it's really bright area after the bladder because the ultrasound waves can travel really fast through liquid. So it's nice if your patient has a full bladder, turn your gain down, and then just ensure that you scan all the way through. And these are just a few references I had. And then, of course, my contact information, if you have any questions about point-of-care ultrasound. And now, as I said before, I really want to save some time, since we're already kind of short, to let's do some scanning, okay? So if you can try to evenly split yourself into 2 groups, we're going to start with some scanning and some live demonstration.